Good evening, all. So today, for our critical care forum medicine, our next session is on electrocardiography. So today we'll exploring the intricacies of electrocardiography and its application in clinical practice. So I am delighted to introduce our esteemed speaker, Dr. Tanmay Kulkarni. He is interventional cardiologist and TAVI expert at Jupiter Lifeline Hospital, Baner, Pune. Sir is academic and clinical gold medalist in DM cardiology from Amrita Institute of Medical Sciences. Sir holds IA Modi Academic Excellence Award in MD Medicine. Sir has participated in planning 100 TAVIs as per CT and artificial intelligence software 3 Mensio. Sir has specially trained in intracoronary imaging, IVUS, and OCT at Howard University. And Sir's extensive knowledge in cardiology will undoubtedly provide valuable insights to our audience. I welcome Dr. Tanmay Kulkarni. Over to you, sir.
Hello, Shubham. Thank you for your kind introduction. And I'm delighted to be a part of this forum, which is very important forum, which represents nationally clinical pharmacists, and ECG being very important part in cardiology, along with the drugs, the pharma, for all the drugs and entire pharma industry is so big now. So there is a specialization is needed, and such topics especially focused on ECG and some changes due to drugs and some basics of ECG will really help you to understand more, because being clinical pharmacist, the routine rounds in ICUs and wards and the insights you give to doctors and to nurses, that there are some interactions with drugs and which drug we can switch, which drug is harmful in some way, and that really help patient to get better in a right way. So that's why I'm very happy that we work with clinical specialists in pharma industry like you, clinical pharmacists. So I'm very happy to be part of this program. And let's start. If you say we can go ahead. If you just say yes, and we can go ahead.
Yes, sir.
Okay, great. Okay, let me share my screen.
Yes.
Okay, so is it visible?
Yes, sir. It is visible.
Sure. So let's go ahead. So today's topic is ECG and the practical basics of it. I won't go into much of the theoretical basics because theory is available everywhere. Theory is available in our textbooks. Theory is available in on YouTube also, on Google also. So whenever we read ECG theory, it gets uh, little little confusing every time we read it, because there are many terms and many theoretical explanation, and which gets very difficult for to apply in a routine life when we don't understand it actually what they mean. So today's class is focused on more of practical basics. So this is the normal ECG. Okay, so this is the normal ECG. Let's understand what is normal ECG. And do we have pointer here? I think yes. So laser pointer. Okay. So when we see that there are waves like P followed by QRS followed by T. So these are the waves of the ECG which are most commonly seen. There are some other waves, but most commonly we see this P, QRS, and T. If they are in this line along with negative QRS, that is negative P, negative QRS in AVR, and positive in 2 and AVF, this we know this is the normal sinus rhythm. Okay, so normal sinus rhythm means rhythm is coming from SA node and ECG is normal. This is how normal ECG looks, and from V1 to V6 and from 1 to AVF. So 1, 2, 3 are the limb leads. AVR, AVL, AVF are also limb leads but augmented. A stands for augmented, and V1 to V6. So these are the chest leads. So just see, understand. So the R component, which is a positive of QRS, is very small in V1, which increases in V2, goes on increasing in V3, V4, V5, and V6. So V5, V6, we have completely positive QRS, while in V1, it is just starting. More of negative. What does it mean? So this means that this is how the normal ECG looks. So R becomes increasingly positive from V1 to V6. So abnormal ECG is something which is other than this routine ECG. So understand, again, we'll repeat, this is the normal ECG. These are the chest leads. This is how QRS complex looks in chest leads. This is how QRS complex looks like in 2, this which is a important lead, that is 2 PQRS followed by T, and inverted in AVR, positive in 2 AVF or 1 AVL. So this is a normal ECG. So let's understand this. This is the abnormal ECG. But let me ask you, which patient is on one drug? So which drug this can be? So this drug, let's guess. First, let's understand what is abnormal in this ECG. This is the abnormality. So patient is receiving one drug. Being a clinical pharmacist, you know if one drug, which was very important, if it creates toxicity beyond the certain acceptable limits, this is how it looks on ECG. So that's digoxin effect on ECG, digoxin drug. If digoxin effect we have to understand, then this is how the Dallas mustache sign. So this is how it looks. See, look at his mustache. Yeah, the similar thing. Yeah. So this is the effect. So if you see such effect and patient is on digoxin, we have to understand, okay, digoxin might be causing extra level than routine acceptable range. Let's go to our basics waves. Basic waves, what we look in the first ECG. P is the first wave, which is for atrial contraction. QRS is one wave, which is for ventricular contraction, that is depolarization. And T wave is for repolarization of ventricle. So P wave for atrial depolarization, QRS for ventricular depolarization, and T wave is for repolarization. So where is the atrial repolarization? It is somewhere buried inside the QRS. We usually do not see with routine 12 standard ECG, 12 leads ECG. This is the extra wave, U wave, and there are some intervals, QT interval, PR interval. So let's discuss more on QT interval in coming slides, because this is the most important part for clinical pharmacists to look for. ECG is nothing but the recording of the electrical activity of the heart. So it's a graph, it's an electrical graph, which records activities from SA node to AV node to all the two bundles and the Purkinje fibers. So SA node to AV node to main bundle, that is bundle of S, from left side LB, and the right side is right bundle RB. And there are some other distally Purkinje fibers. So whenever impulse travels through this specialized conduction system, ECG is being recorded, and we can see on the graph that how the current is traveling, where it is traveling, is there any block, is there any abnormality of that muscle through which it is traveling, and this is how we understand the abnormality of the ECG. So routinely in clinical practice, we do 12 lead ECG, which is the standard one. ECG, we call it in India, while EKG is the term used in United States. So both are same. Here, as we see, as we saw already on the first slide, there are three standard limb leads, 1, 2, and 3. There are three augmented limb leads, which is AVR, AVL, AVF, and 6 precordial leads, that is chest leads. This is how these are placed. AVL, that is left, R for right, F for foot, which is on the left side. Right foot remains neutral, that is black. And the chest lead placement is like this. V1 in the fourth, there is a fourth intercostal space. We count at the angle of Louis, second, third, fourth. So fourth space on the right side, V1, V2 on the left side, and the remaining leads are given in this position as mid-clavicular and mid-axillary line. So these are the chest lead placements. This is how these leads look when we look from above. So sternum on the right side V1, sternum on the left side V2, and again as we described. This is the same thing, but what I really want to give you one idea is we always put V1 and V2 in the fourth intercostal space, but sometimes if some operator puts ECG leads V1, V2 on the upper side without understanding the V4 space, then this may create some abnormality on the ECG, and we have to understand this. For example, they are putting in the second space, third space. See, this is if we put in normal space, this is how ECG looks. But if we put somewhere above, this is the abnormal ECG. See, the pattern is abnormal, but ECG is normal, but the pattern is abnormal because the leads are not correctly placed. So very important that if we have to understand the correct ECG, we have to understand how to take the correct ECG. This is the first step. Okay, so this is one of the ECGs, what it shows. So before that, I just want you to understand something more, okay? ECG and OBGY is the mnemonic. Is it? No. OBGY, no. RBGY. So what is RBGY? Everyone knows OBGY. OBGY is obstetrics and gynecology. So RBGY, just replace O with R. This is how we place the leads. On the right side, we put red lead, R for R, right for red. Then follows the black, then green and yellow. This is how we have to place the leads. So why I had shown this ECG at the first place? So to make you understand that if we put the limb leads in a wrong way, this is how it happens. So AVR comes positive. Actually, in the first ECG we have seen normal ECGs when AVR is negative. So if AVR is positive and one AVL is negative, understand the limb leads are wrongly placed. So always see first whether the AVR is negative and one AVL is positive. If it is not there, limb reversal is the diagnosis. And to avoid limb reversal, understand the mnemonic RBGY. Okay. So coming to the next part, next chapter, that how we calculate the rate on the ECG. So ECG, as we know, we have less time in clinical practice. To sit and read ECG for 15 minutes is not going to be possible. So we have only 1 or 2 minutes to understand ECG. So first thing we are going to see whether it is properly placed, leads, AVR is positive or not, whether properly ECG has taken or not. This is the first step. Second stage, we say what is the heart rate, and the heart rate is by the big boxes. So between the two QRS complex, if the big box is 1, then heart rate is around 300. So similarly, if 2, 150, 3 boxes, 100 rate, 4 boxes, 75, 5 boxes, 60. So rather calculating the heart rate, this is how we directly calculate by counting the big box. So it gets very easy and fast. What kind of pathologies do we really understand from ECG? So ECG, almost everything we can understand because it has been studied for so many years in much depth. First is arrhythmia. That is the main problem because rhythm issues are studied on ECG. Myocardial ischemia and infarction, these still remains very important in today's practice also. After almost more than 100 years that ECG was invented, still it is remains the first test which we do when patient is having chest pain. Pericarditis is also seen as a cause of chest pain. Then chamber hypertrophy because of hypertension or some other problems. Then electrolyte disturbance, low sodium, potassium, calcium, all these things. Mostly calcium is what we are interested in. And drug toxicity, what we saw in our second slide, digoxin drug toxicity, and drugs which prolong QT. So we are going to cover that soon. Okay. Before that, I just want you to understand how we report ECG. So in a simple 8 steps, we report ECG. First goes as verification of the standardization and leads. Second is heart rate, which we have seen, big boxes. Third is rhythm. Sorry, second is rhythm. That is a sinus rhythm or some arrhythmia. Then we look at P interval and P wave and PR interval. Then we look for QRS complex, which is what is the duration, what is the axis. Then we look for ST and T changes, ST segment and T wave changes. Then very important QTC, QT interval. And in there, are there any additional waves, anything extra do we see on ECG? These are the 8 steps for reading ECG in a standard format. This is what we are talking. This is the P. This is the PR. This is the QRS. And this is ST segment. This is T wave. This is QT interval. Okay, so this is how we look. So ECG eight steps. First is heart rate. Second, rhythm. Third is P and PR. Fourth is QRS. Fifth is ST and T. And sixth are extra any beats. What is the QT interval and any extra waves. This is how we report routine ECG. So QT interval, I want you to focus on QT interval. QT interval is 0.32 to 0.50 seconds as the normal interval. So below this is short QT, above this, that is 0.50, is prolonged QT. And being from clinical pharma side, I want you to give me some uh, suggestions on this. So which other drugs you know which cause QT prolongation? So QT interval, as we know, if more than 50 is prolonged, then which drugs are responsible? And there you will be very surprised that there is not even a single drug. That's not only one drug. There are many drugs. There are many drugs which cause QT prolongation. So one section is antiarrhythmics, amiodarone, sotalol, quinidine, procainamide, ibutylide. There are antimicrobials, very important. Pay attention. Ciproflox, levoflox, very commonly used antibiotics. Clarithromycin, erythromycin, ketoconazole as antifungal. All these may cause QT prolongation, very important. Antidepressants like amitriptyline or doxepin, fluoxetine, very routinely used, may lead to QT prolongation and arrhythmia. So if patient develops sudden cardiac arrest or patient develops ventricular tachycardia due to QT prolongation, always check whether was he on any of the drugs which are mentioned on this slide. Then antipsychotics like haloperidol, which is routinely used, quetiapine, all these antipsychotics may lead to QT prolongation, and some others drugs are also there. So there are many drugs. So I just want you to do one exercise, that whenever you go for your rounds as clinical pharmacist in ICUs, in wards, just take out the ECG of that patient and read what is the QT interval. If it is more than 50, just understand, is he on any of such drugs along with the electrolytes? Like, is there any low potassium, high potassium, low calcium, high calcium, any abnormality of the electrolytes? So this is the exercise I am giving to you from today's lecture, that always check QT interval, which is the most important for clinical pharmacist considering ECG. This is what we were saying, but I want you to pay attention on class 1 antiarrhythmics. This is the classification one, the famous classification, which is class 1, 2, 3, and 4 antiarrhythmic classification. Important for us in today's lecture remains class 1, especially A, quinidine and procainamide. These are notorious to cause QT prolongation. That's why 1A remains important for us. ECG standardization is very important. Look at this. This is the 2 boxes tall standardized wave. This is the wave of standardization. This is how it looks when ECG is standardized. If it is low, like half standard, QRS is going to look small. If it is a high standard ECG, QRS is going to be abnormally tall. So always understand whenever interpreting ECG, always look at standardization. Is it normal? Is it half? Is it tall? Okay. Let's understand some very important ECGs which we should never miss. And every medical person, whether he is a doctor, whether he's clinical pharmacist, whether it's nursing staff, or whoever working in hospital, few ECGs are important because usually emergencies come and we have to understand the pattern. If we look at this pattern, we know this patient needs to be referred to a cardiology department. Okay. So this is the first pattern. See, this is the major heart attack, ST elevation. Okay, so this is the major heart attack, anterior wall MI, and patient should be immediately subjected for primary angioplasty. So STEMI remains the major attack, and this is how it looks: ST elevation, very tall ST along with T. And there is some other pattern of ST elevation in this second line also. So it's not a single ST elevation pattern. There are many patterns, and these are few of the patterns. These are heart attack related ST elevation patterns. Secondly, inferior wall MI, STEMI, inferior wall STEMI. So ST elevation is in 2, 3 AVF. So these are inferior leads. From V1 to V6, these are anterior leads. So if ST elevation is from V1 to V6, anterior wall MI. If ST elevation is in 2, 3 AVF, inferior wall MI. Remember ST elevation, ST depression looks like this. This is the PR segment, and this PR segment below that is ST depression. PR segment above that is ST elevation. This is how it looks: ST depression, ST elevation. Okay. Most important ECG. This is patient develops sudden collapse, and ECG is this. What is the next step? Next step remains DC shock, because this is ventricular tachycardia. Appreciate the broad QRS complex. These are very bizarre. There are no proper QRS which we saw on the previous ECGs. So this is something very broad. So this is broad QRS tachycardia. The most common diagnosis remains ventricular tachycardia, and we should shock this patient, especially when in hypotension. What is this? Again, this is ventricular tachycardia, but see, QRS is not that broad. But if we see here, this is the normal QRS, and this is the VPC, ectopic. And then similar pattern has repeated. That means this is ventricular tachycardia. But this can be supraventricular tachycardia if we look at this in this lead, the above lead, that shows as narrow QRS. So even if we see narrow QRS tachycardia, but when patient collapses or patient is having no pulse, we should decivert this patient. So this is the ECG, and patient presents with palpitations and syncope. Again, this is the tachyarrhythmia. This is the first thing. Second thing, this is ventricular tachycardia. Okay. So why I'm showing you all these things? Because there in the practical life, it is much confusing that whether it's narrow QRS, whether it's broad QRS, whether it's VT, whether it's SVT. The only thing you should understand in a clinical practice is if patient develops such tachycardia on ECG and is having syncope or hypotension, we should decivert this patient in emergency and then evaluate whether was he on any drug, whether QT was prolonged, whether is he receiving any antiarrhythmics. So this is how we have to evaluate the patient. So once we decivert, sinus rhythm is back. Okay, so atrial fibrillation is very important because atrial fibrillation is irregular rhythm which may lead to stroke, which may lead to clot formation. So that's why identifying this rhythm is very important. So very easy, narrow QRS, but irregular rhythm. See, 3 big boxes here, while 4 big boxes here, only 2 big boxes in this QRS. These are waves. So what does it mean? This is irregular rhythm and narrow QRS, absent P waves makes it atrial fibrillation. As we know, uh, the drugs are very important in atrial fibrillation. Currently, in non-valvular AF, we are giving newer anticoagulations like NOACs, which also known as DOACs, which is direct anticoagulation, like rivaroxaban, apixaban. All these are new anticoagulations which we give for especially non-valvular AF like old age. Still, for moderate to severe mitral stenosis and atrial fibrillation, warfarin remains the best drug for now. But for the non-valvular, we are going to give NOACs or DOACs. Then comes the rate limiting, then comes antiarrhythmic. So AF has many drug components, and you know it better because you are dealing with these patients in ICUs on every day. Okay, so what is the diagnosis in this ECG? First, understand this ECG, what is the rate? Rate is sinus bradycardia or just bradycardia, we can say. And then where is the P wave? P wave here, then here, then here, then here, then dropped. So it can be the type 2 AV block, so which is prolonged PR interval and then dropping, can become confused with complete heart block also. Okay, what is this? So this is sinus bradycardia or some other bradycardia, but are we sure? So as we know, the speed of this ECG is 50. I want you to understand speed of normal ECG is 25. So if you make it double, you get such bradycardia, which is actually, there is no bradycardia. Okay, so ECG rate is very important. The paper rate, the speed, 25 mm has to be normal. If you have doubt, we can do it with 50. If there is any doubt, hidden waves to find out. But standard 25. What is this ECG? This ECG is showing, see, these are the P waves, these are the QRS waves, and there is no correlation, and there are skipped QRS in between. What does it mean? This is complete heart block. So if patient is on not on beta blockers, you are seeing a patient, he's having severe bradycardia. You check his chart, and there are no beta blockers, there are no calcium channel blockers, there are no antiarrhythmics like amiodarone. So there is no any additional cause to cause bradycardia, right? Then what is it? It has to be arrhythmia. So there are two types of arrhythmias. One is tachy, one is brady. Tachy means high heart rate, brady means low heart rate. So this is the low heart rate arrhythmia, that is bradyarrhythmia. And there are many types. So the two we have seen, this is a complete heart block, while the first one we have seen as type 2 heavy block. So thank you for your patient listening, and I had a very good time here. Please feel free to ask questions in the chat box. And over to you, Shubham. I'll stop sharing.
Thank you, sir. Thank you so much for this insightful session on ECG. So we have a couple of questions. So, sir, how we will differentiate between supraventricular tachycardia and normal tachycardias?
Okay, so tachycardias uh, are into two categories. One is supraventricular, and second is ventricular. Usually, simple rule goes as ventricular tachycardia will have broad QRS, while supraventricular tachycardia will have narrow QRS. Regularity, irregularity is a different way of understanding, but one thing if we have to remember, narrow QRS is SVT, broad QRS is ventricular. There are some exceptions, but for grossly, we have to remember this.
Yes, sir. Thank you. So next is there any drugs other than digoxin which can cause cardiac toxicities and which are mainly seen on ECGs?
Okay, so on ECGs, as we discussed, QT prolongation and drugs These are the very important factor. Like digoxin, there used to be few drugs which are not in the available in the market for now, which were notorious to cause a very bad effect on the heart. But currently in available market, if we have to know, we have one drug that is digoxin. Second, we have to understand all the drugs from like QT prolongation. As such, there is no toxicity of any drug in the available current market. And also, I would really appreciate if from your side, if you put any insights like you have encountered such cases, that would be very helpful.
Yeah, we generally see the QT prolongations only. So recently I had a case in ICU, or the ICU one. So the patient was on posaconazole and levofloxacin, and also on clofazimine. So it caused QT prolongation, but I have seen that he was also hypokalemic. So I have informed to our ID physician that it might be due to hypokalemia. It was in QT prolongation. So later we have corrected the calcium levels, potassium levels, and then the ECG was normal.
Amazing, amazing. Great catch, because this is very important things with multiple drugs like this.
Yes, drugs
We are
like
always
this.
confused that which one is responsible. And most common
Yes,
remains electrolyte abnormalities. Second most common remains drugs.
drugs. Right. Yes, sir. Thank you so much.
Okay, thank you, Shubham, for
Thank you, sir.
having me. Yeah.
Thank you. Thank you so much.
So we'll close the session, right?
Yes.